Okay, for the self-assessment for this chapter, the patient with alcohol or substance use problems. Let's start with this. A 54-year-old man reports consuming a liter of vodka per day. Which of the following symptoms is not consistent with alcohol dependence? A. He feels compelled to drink. So we are talking about alcohol dependence, okay? A. He feels compelled to drink. B. After having a drink, he feels shaky and sweaty. C. He started off by drinking a quarter liter of vodka per day, but now needs a liter to have the same effect. D. He has noticed his mood has been low since he started drinking every day and thinks this might be due to alcohol. And of course, the answer is B. After having a drink, he feels shaky and sweaty. Because alcohol withdrawal would be suggested by symptoms of shakiness and sweatiness after a period of not drinking, not after having a drink. Onset of such symptoms after drinking is suggestive of comorbid anxiety disorder or physical health problem like angina, which may be related to alcohol consumption, like atrial fibrillation. The other options are all features of alcohol dependence: consumption, compulsion to drink, tolerance, persistent despite harm, neglect of other activities. So the symptoms of dependence not listed are difficulties in controlling alcohol consumption and withdrawal symptoms. This is another option. He has stopped going to visit his family because they don't like him to drink. Okay. Another question. A 57-year-old woman described auditory hallucinations telling her that she was evil. These started a week ago, after several months of heavy alcohol use. She is socially isolated. Her mood, concentration, and memory were normal. Other than slightly abnormal liver function tests, physical examination and investigations were normal, and the breath alcohol was undetected. What is the most likely diagnosis? A. Delirium tremens, late onset schizophrenia, hepatic encephalopathy, alcohol hallucinosis, Wernicke-Korsakoff syndrome. Okay. Okay. So, again, we have 57-year-old woman with a hallucination. Okay, no problems in memory or other things. Okay, the answer is D. This is classic alcoholic hallucinosis. Note the absence of memory or attentional problems, excluding delirium tremens or Wernicke-Korsakoff syndrome. Late onset schizophrenia should be in the differential diagnosis, of course, but it's unlikely in this case. Social isolation is often a cause or consequence of alcohol misuse. For hepatic encephalopathy is excluded by the otherwise normal physical examination. So that's it. The third question here. A 62-year-old sailman is admitted to an orthopedic ward following a fractured neck of femur. 2 days later, before surgery or to repair his hip, he appeared shaky, confused, and disoriented, and tells you that he can see a small horse on the table. His wife discloses that he had been drinking a bottle of whiskey per day in the 3 months prior to admission. Which of the following aspects of his management should be delayed? Benzodiazepines, parenteral thiamine, full physical exam, neck of femur repair, consistent nursing care. Okay, this man is delirious, and the history of alcohol use suggests okay, so this is likely to be alcohol withdrawal delirium. And we have note here that the visual Lilliputian hallucinations of small figures was there, which are typical of alcohol withdrawal. In this case, any surgical intervention should be delayed pending improvement in the delirium. So the answer would be D, neck of femur repair. Unless, of course, it is felt that the fracture itself is a significant contributor to his presentation. The other options are all interventions which should be offered in delirium tremens. Benzodiazepines are used for alcohol withdrawal, but not for other sorts of delirium. He should be empirically treated with parenteral thiamine, as it is very difficult to exclude Wernicke-Korsakoff syndrome in delirious patients, and the consequences of missing it can be severe. So we use parenteral thiamine empirically. A full physical exam may highlight evidence of Wernicke-Korsakoff, like ophthalmoplegia, ataxia, or highlight other contributors to the delirium, like chest infection. Consistent nursing care will help to calm and orient the patient. Okay. Question number 4. A 27-year-old man comes to your outpatient clinic and tells you that he has been injecting heroin on a daily basis for several months and wants you to restart his methadone to help him stop. What is the most appropriate initial step in patient care? A. Prescribe his previous dose of methadone. B. Give him some dihydrocodeine to use first. C. Obtain a urine sample for drug testing. D. Refer him to the drug counseling service. E. Give him advice on harm minimization. So, first thing first, the answer is E. So, do no harm. So, to avoid harm, this is first. Providing harm reduction advice is always important and can be effective immediately. Directing him to a needle exchange service, offering screening for blood-borne viruses, offering a home naloxone injection kit, and so on. Prior to any substitute prescribing, it is vital to establish that the drug being substituted is actually being used. So making a urine drug testing the next initial step. So it is a good answer, but it is not the first thing to do. Obtain a urine sample for drug testing. Prescribing methadone to someone who is not opioid tolerant can be fatal, actually. Similarly, prescribing his previous dose of methadone could be fatal, as he may be less opioid tolerant now than he was previously. It is necessary for methadone doses to be initiated at low level and gradually increased, if required, of course, so titrated against withdrawal symptoms. Referring him to a drug counseling service will be appropriate if he wishes to engage. Question number 5. A 35-year-old woman asks you about safe limits of drinking alcohol. You know the answer is 14 units per week. However, she asks you to explain this in terms of how many drinks she can safely take. What would you tell her? Actually, I think this question is an old question, because there is no safe limit for drinking alcohol. And anyways, let's read the answers. 6 pints of continental large, 5.3% alcohol by volume per week. Half bottle of premium gin per week. 2 bottles of red wine per week. A large 3 bottles of strong white cider per week, or 6 bottles of alcopops per week. So we're talking about 14 units per week. So to calculate alcohol units, we take the percentage of alcohol by volume, and we multiply it by volume in liters. Okay, so for example, we have so we multiply 568 mil by, of course, 5.3%. Okay, so we need to calculate that. Let's just stop to do it. So the answer is B, because when you multiply 0.35, which is these 350 mil in liters, 0.35 by 40, so 0.35 by 40, so the third of 40 is somehow it's 14. Yeah. Okay, so for the first answer, we talk about 500, so 6 pins of these would be, the answer would be 18 units for this. C, 2 bottles of red wine would make about 18 and something units. 3 liters of strong white cider would make about 25.2 units, and 6 bottles of alcopops would make about 9.7 units. But you should tell the patient that there is no safe level at which to drink alcohol, merely lower to higher risk levels. If she plans to drink the full 14 units, it should be recommended that she spread her alcohol consumption over around 3 days per week. Another question. A 24-year-old accountant confides in you that he has tried cocaine on a work night out. He experienced some strange feelings and wants to know whether there were likely to be due to cocaine, or whether he was sold something else. Which of the following symptoms is not suggestive of cocaine intoxication? Chest pain, fast heart rate, fever, hallucinations, drowsiness. So the answer, of course, is E. Because, of course, it is, on the other hand, cause hyper alertness or something. So hyper alertness, tachycardia, hyperthermia, hypertension, and psychotic symptoms arise commonly during cocaine use. Chest pain is very concerning symptom suggesting arrhythmia or cardiac ischemia due to coronary artery spasm. He should be advised to seek emergency medical care if this occurs after consumption. So that would be the answer. E, drowsiness. So this is the question, the extended question for the patient with alcohol or substance use problems. We have these substances: MDMA, cannabis, heroin, amphetamine, diazepam, cocaine, ketamine, methadone, buprenorphine, LAD, lysergic acid, diethylamide. For each of the following statements, okay, select the most appropriate answer from the options above. So, deviated nasal septum. Okay, for that, so for each of the following statements, these would be, some side effects or complications or something that are related to the previous materials or substances. So let's talk about deviated nasal septum. Deviated nasal septum can be caused by chronic snorting, of course, these of cocaine use. So that would be the answer, cocaine, because that would cause damage to the nasal septum. What about depersonalization? Ketamine would be the answer. Ketamine is a potent glutamatergic channel blocker and is a potent short-acting dissociative anesthetic. It is legitimately used in veterinary surgery as an anesthetic agent. It can also be used as an anesthetic and analgesic agent in human medicine. So, okay, depersonalization. The ketamine is answer here. What about bacterial endocarditis? The answer is well known, which is heroin. Intravenous drug use is a major risk factor for bacterial endocarditis, blood-borne virus infection, deep vein thrombosis, and infection site cellulitis or abscesses. Other substances on the list can be injected, but heroin is the commonest injected recreational drug. That's why we answer it with this answer, heroin. For memory impairment, particularly if taken long term, this we need benzodiazepine something. So we are talking about diazepam, like alcohol. Benzodiazepines in general, the intoxication and the long-term use is associated with memory impairment. What about precipitated opioid withdrawal? So, and that's obvious also, because the answer is buprenorphine. Why is that? Buprenorphine is a partial opioid agonist. So when taken by an opioid naive person, it can cause euphoria. Actually, it's just like an opioid for opioid naive person. It can cause euphoria, sedation, and other symptoms of opioid intoxication. However, when taken by someone who is opioid dependent and already has a lot of circulating opioid receptor agonists present, like heroin, it can displace these agonists from opioid receptors and cause withdrawal symptoms, actually. So that's it.